Good morning, everyone. Thank you for coming to join us here this morning for the Senate Standing Committee on Health, Welfare, and Programs committee meeting. Um, Before we begin, I'd like to ask the clerk or assistants for roll call, please. No.
Senator Salino Arbabalto.
Devon?
Yep. Senator Ronnie M. Calvo. Senator Manny Gregory T. Castro.
Stick out.
Senator Francisco Q. Cruz. Senator Jude U. Hofschneider. Senator Karina L. Magofia.
Present.
Senator Paul A. Manglonia. Senator Paul A. Mr. Chairman, 4 members are present and 3 members are absent.
Okay, it's my understanding that Senator Ron Calvo is joining us online, and Senator Dono is excused, and Senator Francisco Cruz is on the way, joining us shortly. So we have the necessary quorum to conduct today's committee meeting. I'd like to thank our legal counsel, Antoinette, and Devon, our legislative assistant, for helping us, and of course our IT person for having this live coverage this morning. With the quorum, let me now ask for the adoption of agenda motion. Any member? It's been moved and seconded. All those in favor say aye. Opposed, nay. I was just going to recommend that after the public comment, though, I wanted to ask for the understanding of the members to proceed to hearing our invited guests this morning before we actually go to the new business of discussing all the legislation under our agenda here. But so at this point, under public comment, the committee will recognize any member from the gallery that wish to come forward and deliver comments or testimony regarding the agenda. Just please state your name and your comments.
Half a day. And good morning, Chairman Manglonia, members no ki Senate, senators and staff. Goho si Liana Manglonia sa Van Hofschneider. Kay gizugini pabites taguzi. Kwasya gini ma proposito no za pabites taguhizi sa no satsaga no paro fatu yaji paro tinis taguzisti. Senate Bill 2430 to amend 1 CMC 28002, 28004, and 28032 to certify non-emergency medical transport ambulances and for other purposes. We are supporting this. Actually, we've been following this bill for quite some time. We're supporting this for the record with some amendments. We would like the committee to consider amending to include a member of the Department of Fire and Emergency Services, to include the Emergency Services Director as part of the Professional Licensing Board member. At the same time, 75% of all the fees that are being levied at the Professional Licensing Board should be given to the DFEMS to advance training and the necessary requisites to execute this act that's being proposed. The other one, we're here as an avid, for Lancera, and I'm not a fisherwoman, but a rancher and farmer. We're supporting Senate Bill 2420 and also Senate Bill 2443 on behalf of Matua Council for Native Chamorro advancement. At the same time, we also support, in line of that, on behalf of Matua Council for Native Chamorro advancement, Senate Bill 2403 to transfer management and supervision of the Soil and Water Conservation District to the Northern Marianas College Creeks and for other purposes. I support this as a former commissioner for the Soil and Water Conservation District for the municipality of Saipan. I wholeheartedly support this. This is the right direction. And also, Senate Bill 2436, I'm here as a citizen and as an advocate for the community. I am very concerned with House Bill 2436. I have spoken to some members in the community in the pharmacy, and I looked at the committee report that was submitted with this, and none of the committee report did not have any of the pharmacies, the private pharmacies, comment on it. The Attorney General is there, and some others from the hospital, but nothing from the Bravo Pharmacy or PHI. It's very important to get their feedback on this. At the same time, there is already a prescription drug monitoring program that's being administered by the Commonwealth Healthcare Corporation. So the committee needs to answer that for the public, maybe in your next committee meeting. We want to know what's going on with that monitoring program, because you're already required as a pharmacy to log into that. And I've spoken to some of the private companies here, and I they deserve to have an answer from the Commonwealth Healthcare Corporation regarding that. Now with House Bill 2416, this is a very important bill, but I'm asking the committee or the Senate for a Senate draft to amend, go back to amend the child support and remove all the, make a rider on this bill to remove the child support age restriction, just like the land compensation, because land compensation doesn't have any year, deadline. Similarly, child support, some U.S. states and territories, or I'm not sure, but territories, I take that back, have an age restriction, which is seven years after the attainment of their 18th birthday, and if they're in college, I think 7 years or, after they attain the age of 24, if I'm not, or 21. Those are the recommended. And so I see here in your agenda, Mr. Chairman and members, that the Commonwealth Healthcare Corporation are here to do a presentation, and also the Medicaid director. And I want to take a rider on that because recently, not several months ago, my husband had an emergency and was sent to medical emergency to Guam because he broke his back. And then from Guam, when they did the MRI, MRI, because there's no MRI here, they found out that he also has a cancer on his bone. So the specialist in Guam that referred him from here, and also two hospitalists at the Guam Regional Medical Center had recommended to transfer my husband to a tertiary care in Honolulu. Unfortunately, the Commonwealth Healthcare Corporation refused to send him, so I had to take my husband on our own. And to access, and my husband has a Medicare and Medicaid as a secondary insurance. My husband could not access the Medicaid because the Commonwealth Healthcare Corporation had worked with the late Governor Palacios to amend the state plan. And in the state plan, which is last year, they included HNP as the anchoring authorization, that the committee must approve the medical referral committee, but now they have a fancy name called Healthcare Network Program, that the Health Network Program Committee must approve the referral prior to Medicaid approving any payments. And this is not only unconstitutional, it's immoral, it's morally and ethically irresponsible. So I'm asking this committee to hold an oversight hearing to address the state plan, why the state plan was amended to include this as part of the requirement to send a patient when they're in emergency to access their secondary insurance. And here with me are bills from the Cancer Center of Hawaii and Pacific Radiology Oncology. That's from Hawaii Strop Medical Center. And here's a denial letter from Medicaid saying that I cannot, my husband, so I will have, I've been paying the Medicaid's part out of my own money, which is unfair because it's money that I don't really have. But I'm very grateful that I have families and friends that did a fundraiser for the first time in 21 years to defray some of the costs. But that's like 10% of. But we really appreciate that. It helps. So I want this committee to please, I beg you guys to hold an oversight hearing regarding medical referral from the transfer from the governor's office over to the Commonwealth Healthcare Corporation, and find out how is it possible that in order for the patient on an emergency to access Medicaid, that the HNP committee, which none of them are specialists, have the capacity to override the recommendation from where they sent the patient, which is Guam Regional Medical Center. So they override three doctors that are ANA specialists that is saying that to send my husband to Hawaii. And with that, I know there's a meeting this afternoon. I will come because I want the government to pay us back for the cost that we incurred. And the Medicaid director administrators here, and I think the CACC chairperson also is here. Maybe you guys can coordinate and have an oversight hearing, and because the public wants to know, and myself too. Sizusmase for your time.
Sizusmase, Liana. Any other member of the general public wishing to come forward? Please do so now.
Good morning, Mr. Chairman. Hafade, and thank you for the opportunity to provide testimony. This is regarding CNMI House Bill 24-36, legislation proposing the establishment of a prescription drug monitoring program in the Commonwealth of Northern Mariana Islands. The Commonwealth Medicaid Agency supports the intent and public health objectives of this measure. A PDMP is a critical modernization tool that enhances patient safety, strengthens prescribing oversight, and improves program integrity. Its implementation will align the CNMI with national standards supported by the Centers for Medicare and Medicaid Services and the Centers for Disease Control and Prevention. Importantly, this legislation also aligns with the CMA's forward-looking initiative to modernize pharmacy oversight through the future acquisition and implementation of a pharmacy benefit manager, a PBM. A prescription drug monitoring program serves as an electronic database tracking controlled substance prescriptions. It enables prescribers and pharmacists to identify potential misuse or diversion, prevent doctor shopping, improve coordinated care, and reduce opioid-related risks. For Medicaid programs, PDMPs serve as a powerful program integrity tool. They allow real-time or near real-time monitoring of prescribing trends and provide data that can be integrated into utilization review systems. For the CNMI Medicaid program specifically, a PDMP would strengthen controlled substance oversight, improve beneficiary safety, reduce risk of federal audit findings, and support fraud, waste, and abuse prevention. The CMA is actively exploring the procurement of a pharmacy benefit manager as part of its broader Medicaid enterprise modernization efforts. A PBM would centralize and strengthen pharmacy claims processing, formulary management, rebate negotiations, utilization review, clinical oversight, and step therapy protocols. The implementation of a PDMP under House Bill 24-36 would significantly enhance the effectiveness of a PBM model by providing an additional layer of prescribing transparency and data analytics. Together, a PDMP and a PBM would allow cross-referencing of prescription data with claims data, support opioid stewardship initiatives, strengthen lock-in programs for high-risk beneficiaries, improve cost containment strategies, and enhance real-time intervention capabilities. In short, House Bill 24-36 complements and strengthens the CMA's modernization roadmap. From a Medicaid operational perspective, integration between a PDMP and future PBM would improve and enhance monitoring, which would reduce unnecessary pharmacy expenditures, inappropriate scribing, and duplicative services. It would also strengthen federal compliance. CMS has emphasized opioid oversight and program integrity initiatives nationwide. A PDMP, especially when integrated with PBM analytics, demonstrates proactive compliance and modernization. Combining PBM analytics with PDMP data allows for sophisticated reporting, provider profiling, and predictive modeling. While the policy merits are strong, implementation requires sustainable funding. Initial PDMP implementation may require system acquisition or vendor contracts, integration with Medicaid claim systems, provider training, and regulatory framework development. If strategically aligned with PBM procurement and others, integration costs may be reduced through bundled vendor solutions. Recurring expenses are another issue to consider. While certain Medicaid administrative components may qualify for federal financial participation through CMS, not all PDMP activities are matchable. Therefore, local appropriations will remain necessary. The Commonwealth Medicaid Agency supports the intent of House Bill 24-36. However, we respectfully emphasize that sustainable local funding is essential. Federal participation may offset certain administrative components, but will not eliminate Commonwealth obligations. Integration planning with the future of PBM must be also deliberate and properly resourced. In conclusion, the establishment of a prescription drug monitoring program is a meaningful step toward strengthening healthcare oversight in the Commonwealth. When paired with CMA's future PBM implementation, House Bill 24-36 becomes part of a coordinated, forward-looking strategy to protect beneficiaries, strengthen prescribing oversight, improve fiscal stewardship, enhance federal compliance, and modernize the Medicaid program. The CMA stands ready to work collaboratively with legislature, the executive branch, and CHCC to ensure that this initiative is implemented effectively, responsibly, and sustainably. We'd also like to just make a comment also in regards to Senate Bill 24-30. The Commonwealth Medicaid Agency supports the intent of this bill, ensuring that NEMT providers meet clear safety, operational, and quality standards. It's critical to protecting Medicaid beneficiaries, improving access to medically necessary services, and aligning the Commonwealth with federal requirements under 42 CFR subsection 431.53, which mandates that state provides transportation to eligible beneficiaries when medically necessary. Importantly, the CMA has already implemented NEMT policies approved by the Centers for Medicare and Medicaid Services. These policies establish operational guidelines, provider qualifications, and billing protocols for Medicaid NEMT services in the CNMI. Senate Bill 24-30 complements these policies by creating statutory authority for the certification of non-emergency transport ambulances, ensuring oversight, quality assurance, and regulatory alignment with both federal and Commonwealth standards. It is critical to note that SB 24-30 should be considered in the context of the CMA's CMS-approved state plan amendment. Any statutory certification requirements must and should align with the approved modes of transportation, operational procedures, and reimbursement methodologies outlined in our state plan amendments to ensure compliance with federal Medicaid rules and avoid conflicts that would jeopardize federal funding. The CMA supports 24-30 with the following recommendations. 1, align certification with CMS-approved state plan by ensuring that statutory requirements are fully consistent with approved transportation modes, operational procedures, and reimbursement methodologies. 2, collaborative standard settings. Engage providers to ensure standards are realistic, enforceable, and promote success and access. Adequate funding. Allocate resources for administration, IT systems, training, and ongoing monitoring. And 4, operational oversight. We need to establish clear enforcement and reporting mechanisms to maintain safety, compliance, and program integrity. In conclusion, SB 24-30 provides an important framework for safe, effective, and accountable non-emergency medical transportation. By ensuring alignment with CMS-approved NEMT policies and state plan amendments, the Commonwealth can protect federal funding, enhance beneficiary safety, program integrity, and operational efficiency, and strengthen Medicaid's program oversight. The CMA stands ready to collaborate with the legislature to implement this program efficiently, responsibly, and sustainably. Thank you. And again, just for the record, my name is George Cruz, Director for the Commonwealth Medicaid Agency.
Mosi, Director.
Good morning, everyone.
Morning,
Honorable Senator Paul A. Manglonia and members of the Senate Standing Committee on Health, Welfare, and Programs. My name is Jesse M. Tudela. I'm the Chief Operations Officer at Commonwealth Healthcare Corporation. And this is in regards to House Bill 24-36 to establish a prescription drug monitoring program in the Commonwealth of the Northern Mariana Islands and for other purposes. Hafade, Turo, Honorable Chair Manglonia, and committee members. I, Jesse M. Tudela, Chief Operations Officer of Ancillary and Support Services at the Commonwealth Healthcare Corporation, and also the Project Director for the Prescription Drug Monitoring Program. I'm here today to express strong support for House Bill 24-36 to establish a prescription drug monitoring program in the CNMI. Access to accurate and up-to-date information is essential to delivering high-quality medical care. One often overlooked but critical aspect of that care is having a complete and accurate medication history. How often do we forget what medications we have at home or what was last prescribed to us? This bill addresses that gap by allowing healthcare providers to securely access a patient's filled prescriptions from any pharmacy in the CNMI, giving them a clearer and more complete picture of a patient's treatment history. Importantly, passage of House Bill 24-36 will align the CNMI with national standards and open the door to critical federal funding opportunities. All 50 states and 3 of the 5 U.S. territories, Guam, Puerto Rico, and the U.S. Virgin Islands, have enacted PDMP legislation. In 2024, the U.S. Virgin Islands signed their PDMP into law, leaving the CNMI and American Samoa as the last 2 U.S. jurisdictions without one. Establishing a PDMP will make the CNMI eligible for federal grants to fund its continued development and sustainability, as essential benefit given our limited resources and a strategic investment in public health and safety. Again, there is only 2 more U.S. territories that have not enacted a PDMP legislation. I respectfully and strongly urge passage of House Bill 24-36. We have advocated for this bill since its introduction in 2021, while the House passed a similar bill in the 22nd legislature. It was not advanced by the Senate. We humbly ask this legislature to complete this important effort to modernize our healthcare system and ensure our providers have the information needed to safely care for our community. PDMP program continuously offers the support to all stakeholders. They meet monthly, informing them of the data that has been collected. So the PDMP manager, Mrs. Monica Camacho, and the PDMP coordinator, Mr. Yohei Iwashita, are here today should you have any questions. Thank you, Sizus Masi Giliso.
Thank you, Chairman. We're still under public comment portion of our agenda. Any other member of the general public in the gallery that wish to make comments? We ask you to come forward, please. I'd just like to recognize the presence of Senator Cruz, who joined us a little while ago. Okay, so I guess there is no further public comment. I know original. Mr. Guerrero, please.
Afternoon, Entero. My name is Ted Dilong Guerrero. I'd like to talk about Bill 24-30. What does this bill does and why it matters? What is it? Is this bill about, right? The legislation strengthens and modernizes our laws to ensure clearer rules, stronger accountability, and more effective government oversight. It establishes defined standards, clarifies agency responsibilities, and creates enforcement mechanism to close existing gaps. In simple terms, it makes the system clearer, fairer, and more reliable for everyone. Why is it needed? Over time, laws can become outdated, unclear, inconsistent. When that happens, agencies may interpret rules differently. Business face uncertainty. Residents experience inconsistent enforcement. Government processes become slower and less transparent. This bill corrects those issues by updating the framework and improve how it operates. Key benefits of the community: stronger accountability, clear authority and enforcement standards reduce confusion and prevent abuse of inconsistent application. Greater transparency, defined procedures improve public trust and confidence in government decision. Fairness and consistency, uniform standards ensures that everyone is treated equally under the law. Economic stability, clearer rules gives business and investors confidence, which supports economic recovery and job creation. Better government efficiency. Clarified roles and responsibilities reduce duplication, delays, and costly disputes. How it helps the Sinamay now. The Sinamay is in a period of rebuilding and economic recovery. To move forward successfully, we need predictable regulatory systems, strong public trust, and efficient government operation, modernized statutory tools. This bill helps lay that foundation. What safeguards are included? Defined administrative authority, clear enforcement standards, oversights and reporting mechanism, structured implementation procedures. These safeguards ensures fairness while improving performance. The bottom line, the legislation is about strengthening governance, protecting the public, and positioning the Sinamay for long-term stability and growth. In its forward-looking reform designed to make our laws better for everyone. Thank you.
Excuse me, Mr. Fred Guerrero. There's no other member from the general public that is coming forward. Normally, we would go down the list then on our next item and discuss the legislation that is listed here. However, as I indicated earlier, I intend to go to the next agenda, which is miscellaneous under invited guests. But before I do that, I know some members of this committee probably invited experts or witnesses pertaining to some of this legislation here. And since they're up here already, is there any member that wish to recognize any of the guests that they invited for presentation on any of the legislation, so that I'm thinking before we go down, we can recognize them since they're here already. Any member? Okay, if not, then can I get a motion to amend our agenda so that we can go to item 6 and then come back to item 5 later on?
So moved, Mr. Chairman.
Okay, move and seconded. Those in favor say aye. Opposed, nay. Motion carried. And so, at this point, I want to call up first guest, Dr. Chelsea Cabrera, who will be talking about nursing home and long-term care. Can you say your name and a little background and to the members? Thank you, Dr. Chelsea.
Hi, good morning, Chairman and members of the committee. My name is Dr. Chelsea Cabrera, and I am an advocate for elder care reform in the CNMI. First and foremost, thank you for the opportunity to speak today. Over the past year, I've been aggressively advocating for the establishment of long-term care systems in the CNMI because the need is urgent and undeniable. In the absence of long-term care services, family members have stepped into the role of caregivers, often without training, without respite, and without financial support. Many are doing their best, but some simply do not have the capacity or the resources. I want to briefly reference 4 specific cases shared by nurse practitioner Zoe Stevenson at last year's Population Health Summit. And these are all patients that are at CHCC. So she reported one patient has been admitted since 2023 with no caregiver, no place to go, as no family members are on island. Another patient has been admitted since 2024, also with no caregiver at home and family off island. A third patient admitted in 2023 cannot be cared for because caregivers are unwilling and the patient is uninsured. And the fourth patient has remained hospitalized since 2022 with no caregiver and no discharge placement options. It's cases like these that have significantly contributed to the uncompensated care costs for CHCC, and I'm also advocating for CHCC because the hospital needs our support, and the people from the CNMI would greatly benefit from a structured long-term care system. And this is not just tailored for the Manamkus, right, 65 years and over. This is tailored to individuals with disabilities and our veterans that are seeking these long-term care services and want to return home. The need is evident, and the time to act is now. Thank you.
Mr. Chairman, if it's possible, we have the since you mentioned Dr. Cabrera, since you mentioned about those no family members that can take care of the patient, those patients that she mentioned that was admitted at CHCC. Can we invite the CEO so we can ask the questions? Because this is in regards to patients that are.
Let's bring in maybe I see Paul Jack wants to join in. What about from CHCC? What about from CHCC? Is there anybody? Please join us, and I guess even might as well let's just tackle this with CHCC and the Medicaid director since he's here already, and. We appreciate everyone's present, and so we can have a free discussion here, free flow. And All right, thank you, Senator Cruz.
Thank you, Mr. Chairman, and I appreciate CHCC staff to be, because this is in line to what Dr. Cabrera was stating. I know I have no opposition on the proposed, and that's good for people, that they should have that kind of, assistance to our community, especially the most vulnerable people that needs, caregiver. And since you mentioned about, I believe I've mentioned this back in the past when we had patients that are being admitted, and I know that we cannot deny medical services to anyone, regardless of origin or religion or nationality, right? So, but in that regards, I raise the concern of do CHCC seek for further assistance from, like, legal assistance from the Attorney General, because I believe, and I know it's CHCC is spending a lot of money, without being taken care by their own, because you need additional manpower to take care in the hospital, whatever needs, especially if it's a bedridden patient. I raise this concern that any assistance from, or do CHCC ever seek assistance from the AG's office as to how we can go about with this? Because I know even they don't have family here, but I think how did this patient, if it's a non-U.S. citizen, it is a non-U.S. citizen you're talking about, right? Or you don't? Okay, because I think if it's non-U.S. citizen, no offense to non-U.S. citizen, we have to take care of them because that's what the law is. But we need to find out how did this came in, so we have to find who's the employer of this, so that they can be responsible for their, and not just, even though their employment is already terminated from, but they still have to care for their employer even though it's terminated, because I think the law, if it's back then during our immigration control, everybody has to be responsible, but if it's not renewed, have to send it back, right? But if it's overstay, I think that's why you have to seek legal opinion from the AG as to how we go about with this. If it's not non-U.S. citizen and it's overstay. Now for U.S. citizen, that probably from Guam or from other area that are here, maybe again we could seek other remedy by contacting the other, U.S. areas to inform them that their family is here and hospitalized, so that we can, be able to, at least inform them. And if they don't, if they still don't care to come and attend their family, then what can we do? No, we have to continue, right? So those are the things, like we have to, seek other remedies other than the hospital will be burdened with every single cost, right? Because even CHC, they need funding, right? You guys need funding for you to continue the delivering of the best quality healthcare services, right? But at least to explore some other options, and find ways that they can alleviate the burden on the hospital. I don't know if that's been done, but I raised that many years ago, and I don't know if that's been taken into consideration I'm not against anyone, but at least somebody has to be, to be responsible, because you cannot just, for me, this is my own. I think no country can just abandon their own national at a foreign country, right? That's including us. And even if our people is stranded in a foreign country, government have to reach out and find ways to bring that, our citizens back home, because you cannot just abandon, even though we're not related, but it is from our area that we have to be responsible to bring that person back through government, ways, right? So those are the things that I'm not trying to tell CSU what to do, but I raised this back then, and I want to find out whether because if this is not addressed, we're gonna continue to be burdened. The hospital continue to burden all the cost, and I appreciate Dr. Cabrera for having this kind of conversation to making sure that everyone is been served, no, underserved, especially underserved people. Thank you, Mr.
Yeah.
Mr.
So basically, we have discussed this. I understand in the past. So Dr. Chelsea is emphasizing the dire need, and so let me ask CHCC, how many SOTS patients do you have that should be released, but because there's nobody to care for them or stuck in a hospital today?
Hi, good morning. My name is Helena Palacios from CHCC. I don't have the exact figure for today, but as of 2025, the highest we've had at one time is about 6. And as Senator Cruz had said, and mentioned that some of the measures that have been suggested, part of CMS regulation for the hospital is to have a utilization review team, which also collaborates with the social work team for the hospital. So every day there is a daily discharge that talks about the patients that are currently admitted in the hospital, where all of their issues, from social issues to even their clinical and medical issues, are discussed. And one of the things that is a CMS regulation is safe discharge. So we actually cannot just let people go whether or not they have a home, which has brought up concerns that, Dr. Cabrera is talking of. We are, when they are non-U.S. citizens, we do, our social worker team does work really hard along with our utilization review in working with their embassies to see how they can possibly return to their native countries, or just even assistance with housing here in the CNMI. We've seen embassies and even, nonprofit donations for that to help alleviate some of those circumstances, even as far as things that are food during their discharge. But there have been times where there is absolutely no response also from anybody to fully take care of them. A lot of these patients that we're talking about, as Dr. Cabrera mentioned, are those that need assistance after they've been discharged. So as you know, yes, we do have home health agencies, but there are also limitations to them of what they can provide. There has to be a doctor's order and all of that. But what we're talking about also is basic caretaking. And as you know, those are some of the limitations, and it is also coming up intercross with some of our immigration policies. We are having most of the caregivers that maybe 20 years ago it was, I don't want to say affordable, but easier to come by and do all of those, all the paperwork and documentation. It is harder now. So, such solutions like nursing home and those things are why it's coming to the forefront. Even with our insurance agencies like Mr. George Cruz that's here, Medicaid also has their limitations of what they can cover and cannot cover, especially with what are the services that we're able to provide here. Our home health agencies also are limited in capacity of how many, the amount of CW staff that are coming in, how many have H1Bs that are here versus the population that we're serving. And, a majority, again, of the services happen on SaiPan. We've had some home health agencies reach out to some areas such as Rhode and provide services there at one point, but same thing for Tinian. They're to be able to house and hold the capacity for actual business and turnaround on investments like that has proven difficult. But that is something that we continue to support them when they look forward to it. But yeah, that's my
Senator Cruz, follow.
In line with what I'm saying, I guess this is also to prevent us from, you know, violating any federal laws, you know. For example, even though you want to assist these people, but especially undocumented, we cannot deny medical service. But we need to find out from the authority, the federal government, whether assuming that you're gonna have those patients in your care, in that, and even with what we're having now in the hospital, assuming that those are undocumented, we want to make sure that the federal government's, you know, authorize some kind of approval to continue to be here in the cinema. Because if we're not reporting it, we might get in trouble, and that's to prevent us from getting in trouble from the federal government. And I don't know whether just in trouble, or maybe we might get penalized, or I don't know, maybe the hospital is gonna get in trouble by housing people or taking care of people that are not report, you know, because of course when they come in, the hospital should know the identity of the person and what, right, the status of that person. So this is just a preventive measure to make sure that we don't get in trouble with our federal partners, you know, and because we always need the federal system, right? Because we're having problem with what we're encountering with revenue. So those are the things that I think we should take into consideration. And like I said, no offense to those that are non-new, but we have to make sure that we're doing the right thing. And I thank you for you know, for everyone's cooperation, no? Just to be on the safe side. So,
Thank you, Chairman. Senator Corina?
To the sponsor chairman, Dr. Cabrera, I just want to say thank you for sharing those issues and concerns with the committee. I didn't realize we had that problem, but I appreciate you sharing that. You talked about uncompensated care costs earlier, and I'm just curious, how much of that is attributed to CHCC's total expenditures?
Senator Quinn, I can get that information to you after
Okay.
this committee meeting.
And I just want to understand, right, because it's important to understand what those uncompensated care costs are, because it affects the budget, right, for CHCC's operation. So that when CHCC comes in and talks about, you know, their budget ask and, you know, things of that nature, it's important to understand that although they generate some amount of revenues, right, a big portion of that is funding these types of costs. And as you know, we just have to be mindful of that, because those costs are not recoverable. It's not like somebody's going to come in and, you know, reimburse CHCC for those costs. So I wanted to know what percentage of the total expenses is attributed to uncompensated care costs. And then second, is it by regulation that CHCC is not supposed to release these patients if they don't have someone to care for them? It's regulation. Is it law?
Yeah,
Oh,
CMS.
The CMS, right?
Yeah.
Okay. So then I'm assuming that then if that's the case, then the hospital will just keep those patients at the hospital and continue to care for them, to include meals and all of that, until such time they're ready to release them. Got it. Wow. Okay. What are some of the recommendations that CHCC can suggest to the government, to the legislature, to find a more long-term solution for those kinds of issues that we, like, you know, I'm pretty sure other jurisdictions experience the same challenges, right? So what are some of the long-term solutions that other jurisdictions are doing?
Yeah, I've actually had a conversation with Dr. Cabrera before about this, and you know, it's truthfully, I think in the Pacific and culturally, it's not something that we thought, oh, it's a priority of a problem, right? But we are also in the time where everybody needs to work.
Yeah.
There's not a lot of people where it's one sibling or another that can be a caretaker. So it's brought this to our forefront. You know, we even have times like when we're having our family consultations where it has to be at a specific time or specifically because the kids of whoever's being admitted are, you know, they're in the working force. And so she had mentioned some of her experience with just there's programs honestly in the US mainland that talk about caregiving and the funding that goes along with that, which is really helpful, but that is still in works with having solutions such as a nursing home. And taking on a nursing home is it, you know, it is tremendous. It's opening another healthcare system, and so there's a lot of funding and support that I think for whoever would like to invest in it, you know, also to be in support from the government is really important. And it is a thing that is not, we're not seeing the numbers go down of people who need caretakers or who, and even with the caretakers, truthfully, even with the health of our people, it's not as simple as watching somebody's nang and tang at the house and making sure somebody's home. It is also now needing to have some type of, you know, experience and being able to recognize some of those signs. And so even when there's programs that do training for respite care or caregiver, you know, home caregivers, that's still, you know, we're also, I will say, losing an opportunity because when there are areas such as nursing homes or certified caretakers, those are things that insurances can cover, right? And so, yeah.
Thank you for that answer. So, in talking about nursing homes, I know culturally, right, it's not in our culture to send our parents off or our loved ones to a nursing home. Rather, we try and take care of them. But I also do understand that when family members are in the workforce and they're unable to provide that care, I was wondering if there's such a program, maybe a federal program, that could provide some funding assistance to hire a personal caregiver to be at the home where the patient lives, so that, you know, the family members can go out and work. Is there some kind of assistance at this time?
Going to
Yes,
the director,
Oh.
George.
There actually is a grant that the Office on Aging avails to. It's called the National Family Caregiver Support Program, and they provide respite care, and then they also help with home health services and a plethora of other services for family caregivers. And I just want to echo Ms. Helena's words, because when I conducted my doctoral dissertation, I interviewed 12 family members from Saipan, and 11 out of the 12 family members have had to leave the workforce to render that 24-hour support. You know, they leave the workforce, they don't have any income, so they're dependent on their elderly parents' retirement benefits or Social Security income, right? And so it also creates this cycle of poverty. And then they have to go back, they have to go on welfare, you know, and that's not the trajectory we want to go on, you know.
I mean, geez, I just see a whole bunch of issues that are very, very much interconnected, right? Because when, so I'm asking whether or not there's some funding assistance to hire, you know, someone to provide personal care. But then, you know, it's also mentioned that preferably, right, that you would have someone who is properly trained and has experience to be able to care for patients with needs. And so that, again, if we're just going to go off and start hiring, you know, just an average person to care for, I see a need and a gap within the Commonwealth that we really need to start collaborating with other government agencies to include, so CHCC with maybe NMC, and I don't know, like there has to be some kind of collaboration to be able to offer some type of training and certifications for family members to be able to stay home and care for their loved ones if that's what they choose for, but still be able to be compensated. So it looks like we have a whole bunch of
And
Uh,
another grant that actually supports this is called the Money Follows the Person program, which supports home community-based services. So American Samoa actually availed to this grant back in 2022. It was their first time availing to the grant. They were awarded $4.7 million. They will be applying for the next round, and their goal is to get family members paid. Yes.
I think I recall. Did they? It sounds familiar.
Yes.
They've been to the
Yes,
legislature, right? to
she
provide
did do a presentation back in 2024, the state director
Okay.
for the legislature. Yeah.
And is that something that, do you know if that's something that the CNMI
Yes,
is
so
also?
she's actually helping us with that grant, but there's a lot of there's a feasibility study first that we have to do, and a lot of preparations first. But
Okay.
the grant will be available in 2027.
Okay.
Yeah.
All right. Thank you for that update. And one last thing, Chair. I'm not familiar with what the health. So you talked about home health agencies. What, I'm not familiar what this is. Is that like a? So you were talking earlier
Yeah.
about.
The home health agencies,
Yeah.
they almost like our clinics. Most of them are staffed by nurses and nursing assistants and like the clinical care team. And they have a medical advisor. But these are the people that. So I'll give you an example. You get discharged from your home, but there's some physical therapy that you can do at home that's ordered and covered by your insurance. These agencies, you do choose, and they go based on a doctor's order, and they come to your house like 2 times a week or 3 times a week, and they do what's ordered, and they work with the patient, which like has helped tremendously over the past 20 years, keeping, our main goal is to keep our community members healthy and not coming back to be admitted in the hospital. But that also has limitations. Like a physician won't ever order, okay, this patient's going to have physical therapy from 7:30 to 4:30 Monday through Friday, right? To solve that situation of not having care. And also that's not their purpose at the home health agencies. Their purpose is really to better our community members' health and provide all these services. And they do a variety of things, from physical therapy to the actual, check-ins, even giving immunizations, doing medication, education, all those type of things. So yeah, it's really an extension into the home where a lot of our people are at.
Great. Thank you for that explanation. And just to clarify, these agencies are private company. Okay.
Yeah, and they are also CMS certified, because they also make their money through
Yes.
insurance
Okay,
collections and
perfect.
stuff.
Thank you. That's all I have, Chair. I yield.
Thank you, Vice. Let me recognize Senator Manny Castro at this point.
Thank you, Chairman. First of all, I just wanted to thank Dr. Chelsea Cabrera for coming back to the CNMI, and it's a proven example of when we invest in our scholarship programs. And so I also hope that before I go on to other things, that you have a lot of great ideas, Doc, and I think you should also consider being a policymaker. A lot of our founding members in the legislature were in that same space, and whether it's in the Senate or the House, sometimes you have to grab the bull by the horn and make it happen. And a lot of these issues are policy related, systemic policy changes. Senator Cruz brought up a very good point. I see the effects of changing the law back when the immigration, a federal law changed and a local law was changed, which put more burden on the hospital in terms of uncompensated care. Because a few years ago, when I was in the House and I met with people from like a stakeholders meeting at the hospital, it's majority of the cost is uncompensated care, and A lot of it has to do with uh, individuals that are out of status, right? And this is not about race or anything. This is about there's a reason why the legislators back then made it mandatory that if anyone was to bring in a contract worker, the employer is mandated to provide health insurance. Because now what's happening is, what's happening is all the insurance rates, everything, the hospital cost goes up, and we have to go back to the root of this systemic issue, which is what Senator Cruz was kind of pointing us in that direction. So yes, maybe that legislation was changed back in the day because it was cost that we didn't want to put on employers. But however, it is also unfair to put that on everyone else. So that's something we may need to look back into. At the same time, maybe it also needs a radical approach in terms of the nursing assistants. Again, a federal law and a local law affecting, causing this problem. When I was growing up, my grandma had a housekeeper, and it was twofold because the housekeeper also mentored me as well to be the person that I am today. And it's like a second mom, but my parents were busy working, and it was affordable to recruit from the Philippines, and at the same time, that's how families back then that can afford it it was affordable, right? Median household income is still low, and it hasn't changed since the 90s, but the economy has changed drastically. So we have to look at sometimes the positives. A lot of our own people that moved to the States are in that space. They're working in the nursing care facility. I had friends from Tinian that were all working at a nursing home, relatives from here in Saipan that were, and you know what the owners of the nursing home says, like, as much as we, like the owners of those nursing homes, like, where can we get more of you guys? Because it's, apparent it's just in our culture to be very respectful to our manomko, and so maybe that's another program we need to look into when that those types of industries are developed. I mean, we have subsidies for daycares. We should also have subsidies for adult care, right? And that's something that we may have to work with our counterparts in the House to kind of put in those types of efforts, because we're paying for it at the end. It's just being paid for. It's an expense that's being paid for somehow, but every individual is going to end up paying for it. So why not shift that and start building up the assets that can reduce the costs? It might be even a radical approach. In Navy Hill, there's a lot of old but still structurally sound buildings that used to be housing, but now is in the jungle, but it's still concrete. Resurrecting that and embedding that into kicking out a lot of these government offices that really shouldn't be in a residential house and make it a nursing home. Those subdivisions across CHC next to the school, perfect place for nursing homes. But I just wanted to stress that, Dr. Chelsea, maybe one day you can consider being a policymaker also, so we can work together. But other than that, I just wanted to thank you for your continued advocacy. And the same sentiment to everyone here, two directors. Director Cruz, in your private capacity. Thank you again for helping fill the gap between a lot of the services that the government, is having a challenge with. And in line with what was said earlier, since we have people in the medical space here, I also wanted to commend my fellow colleague, Senator Karina, for our vice president for the bill on kind of like privatizing the emergency medical services. Certifications are really important, and whenever there's an accident, and as the person responding to that emergency needs to speak the same language as the emergency room, and communicating that over the phone, over the radio, and so that when they get to the emergency room, that it's time is important. And as someone who has worked at the college for several years and has oversight over the course guides and the training, I could say that the training from the 90s for the especially when it comes to paramedics, a lot of those courses is not being offered anymore due to costs, right? So again, we need to look at the bigger picture of things and the systemic issues, and I look forward to working with you guys. Thank you, Chair. I yield.
See, Senator Castro. Let me ask the director, George. You wanna comment on some of these discussions at this point? Thank you.
Sure. Actually, if you don't mind, if I have a prepared statement, if that's all right.
Per time.
Okay.
Thank you.
So thank you for the opportunity to speak today on a matter of profound consequence, which is the future of long-term care services in the CNMI and the absolute critical role of consistent, adequate local matching funds to make these services real, sustainable, and operational. Over the past several years, our Commonwealth has faced unprecedented challenges in healthcare delivery, economic uncertainty, workforce shortages, and growing demands from an aging population. Among those demands, long-term care services, including nursing home and skilled care options, are not optional add-ons. They are essential supports that allow our monomnical and vulnerable citizens to live with dignity, safety, and the medical care they require. Today, I speak not just as a director, but as someone who has witnessed the struggles of families, the burdens carried by caregivers, and the genuine fear in the eyes of our elders who want nothing more than to age with dignity. Let me be clear and direct. Medicaid long-term care services are amongst the most important components of a mature healthcare system. They honor our elders, support families, and ease the burdens on caregivers who shoulder these responsibilities with love and sacrifice, which Dr. Cabrera has mentioned. But critical as these services are, they do not come free, and they do not come without a local match requirement that must be funded. We know the costs of long-term care in the United States are extraordinary. For example, the average annual cost of a nursing home semi-private room exceeds $110,000 per year, and a private room can exceed $120,000 annually. Home care, assisted living, and memory care costs ranges from $50,000 to $70,000 annually, depending on the service type. These figures underscore why Medicaid is the primary payer of long-term care services nationwide, because most families simply cannot afford these costs out of pocket. In fact, nationally, Medicaid covers over half of the long-term care expenditures for the elderly and disabled. Under federal regulations, long-term care and nursing facility services must be provided by Medicaid when an individual meets eligibility and medical necessity criteria. These services are defined under CFR 42 CFR 483, which outlines the residents' rights, quality, and safety requirements for skilled nursing and long-term care facilities participating in Medicaid. But federal rules alone do not fund these services. For every federal dollar, the Commonwealth must provide its share of local matching funds to unlock the federal participation. Medicaid is a joint federal partnership, local partnership, not a unilateral federal program. The federal government matches state territorial spending through the federal Medicaid assistance percentage. While the exact FMAP for the CNMI may differ from other territory provisions, the general mechanism holds true. The FMAP for CNMI federal is 83, which means for every 17 cents the Commonwealth spends locally, the federal government contributes 83 cents. That match is not a suggestion. It is a legal obligation. Without it, the federal funds simply do not materialize, and the services we plan, we discuss, or dream about cannot be implemented. Let me be clear and transparent about what we face here. Over the past 3 fiscal years, fiscal year 24, 25, and fiscal years 26, this agency has experienced a reduction in its local budget allocation by an average decrease of 7%. Fiscal year 2026 reflected the highest reduction with a 9% decrease in matching funds compared to fiscal year 25. Instead of strengthening our local share to match expanding federal opportunities, the Commonwealth's investment in the CMA has shrunk at a time when demand, especially for long-term care services, continues to grow. This trend is not sustainable. It has real consequences. Lost federal match dollars that could have been leveraged for services, delayed or deferred program expansions, limited capacity to serve our Manumco population, compromised program planning and continuity. The legislature has been generous in prior years, and we thank you for that support. But we cannot continue to ask the federal government for more while providing less locally. Failing to meet our local match obligation is not just a bookkeeping issue. It results in fewer services, delayed implementation, and unrealized benefits for our people. Let's talk about the human reality for a moment. Our Manumco, the very people who built our families, raised our children, and enriched our culture, deserve better than being left with no choice but unsafe home conditions, overburdened family caregivers, or emergency rooms ill-equipped for long-term care. They deserve dignity. They deserve quality support when they can no longer care for themselves. Medicaid long-term care services make that possible. They provide skilled nursing care when medically necessary, assistance with daily living activities, safe, standardized environments with federal quality oversights, and a pathway for beneficiaries to live with dignity rather than being institutionalized only via crisis. But these services cannot exist with consistent local matching funds, without local matching funds. Funds that unlock federal dollars, but the Commonwealth must commit to providing. Right now, we are at a crossroads. When local funds decrease, federal match dollars are lost. And unlike local funds, federal dollars do not roll over. They are recaptured. Program expansion plans grind to a halt, which this agency experienced in 2023 when the program ran out of money. Infrastructure development is postponed. Provider relationships become unstable. Our ability to plan for future deteriorates. And when we talk about long-term care services, services used by our most vulnerable citizens, Manumco and the disabled, the consequences are devastating. Families are forced to shoulder care privately. Again, Dr. Cabrera shared that. How many have left the workforce to take care of their parents? How many have discontinued going to school, their education, to care for their loved ones? The elders may be left without safe care options. CHC becomes a dumping ground for unmet long-term care needs. And the cost shifts into crisis mode, which is far more expensive than structured preventive care. This is not theoretical. This is practical budget reality. Honorable members, I stand before you with respect, with urgency, and with deep advocacy for the people of the Commonwealth. We must commit to consistent and adequate local matching funds if we're going to provide meaningful long-term care services and overall quality healthcare services for our people. Without that commitment, Medicaid long-term care services cannot be expanded, federal match dollars remain unreachable, and families will continue to struggle, and the agency cannot build sustainable programs. We do not seek charity. We seek partnership and responsibility. This isn't just about policy. This isn't just numbers on a spreadsheet. This is about our Manamco, the people who have built our communities, our culture, and our families. They deserve stability, comfort, and respect in their later lives. When a parent cannot safely get out of bed, when an elder can no longer manage daily tasks, when cognitive decline places a loved one at risk, Medicaid long-term care services provide a lifeline. But that lifeline exists only if the funding foundation is strong. And right now, with decreasing state allocations, that foundation is cracking. Let me say this again. You cannot build what you cannot fund. You cannot sustain a promise that is not backed with resources. You cannot provide care without the match that unlocks federal participation. If local state matching funds are inconsistent, inadequate, or declining, long-term care services cannot be expanded. Initiatives remain unfunded mandates on paper. Beneficiaries continue to struggle with unmet needs, and the CMA cannot responsibly plan or implement services. We in this agency cannot and will not present plans that we know in our hearts we cannot sustain. Not only would that be fiscally irresponsible, it would be morally unacceptable. Our Manamco deserve dignity, our families deserve support, our Commonwealth deserves a healthcare system that cares for all generations. We can create that future, but it requires consistent funding today. With that, again, I thank you for this opportunity.
Sidu Sumasi, Director, for that, those good points, very good points that you raised, we appreciate. Any member, Senator Cruz?
Thank you, Director Cruz, for that very good information that I think the legislature should understand, because we're the this is the place where they appropriate money, no? And I understand that we have we're eligible to have that kind of like matching fund, right? And if we don't take that advantage, we're gonna lose, right? So some of the questions I'm gonna ask, it's within what you said. Like, for example, I don't know if we have the co-consumer directed personal assistance program. I don't know if you have that, but even if I ask that, or even if you have that and we don't have the matching, it doesn't, right? It will not be materialized. And the reason why I ask this, because I think not only the government, even in the private sector, we're having problem with our economy, right? And I am pretty sure that you said it decreased, the percentage decrease on what you're receiving, but the number are increasing, right?
Correct.
There's more people are coming in to be eligible for Medicaid because of cut hours, and even in the private sector, a lot of cut hours. So absent the local funds to match that, you cannot, even though you try your best to accommodate everybody, it won't be possible, because I know that it lies here, right, in the legislature, and I hope we can find other source of revenue to, because I know that even if I ask the federal government money cannot be the matching fund, because I think it will not be allowed, right, federal government to match federal money. So it has to be local funds. So I hope that I'm thinking of somewhere else, but I hope that that agency will continue to allow to assist us in this regards, because I think it's very important that we should attend to those that are very, vulnerable and very, because of the economic decline. So I'm in support into that. But this is only me. I'm not trying to put my colleagues on the spot, but I'm in support into that because even if we think about saving money, what for saving money when everybody gets sick, no? We have to. We can also do a matching on this. Enough money to save people's life because we need these services, right, to keep everybody healthy. So I'm in support of that, and I hope that we have that funding to continue to take advantage on that matching, federal matching. When I came into become a senator, I keep thinking of why we have to, to do matching when we don't have the money. So I just figure out that maybe the federal government will not give us any more money that going to be reprogrammed to something else. So that's why maybe they have this kind of you have to match first and to see whether you have we have the effort and we're devoted to do so, right? Otherwise, because I keep thinking we don't have the money, how can we match it, right? So I think those are the things that it's in my head that I think government also, and I know this is life, but I hope that the federal government, will continue to consider helping us because we don't have any other no source of revenue here besides tourism, and I hope that the federal government, with all this military activity that's happening, will something will come up to really assist our area. And I'm just crossing my finger that we still need more help from the federal government. And I appreciate Director Cruz for laying that this been laid out in the past, but not as thorough as what you did today. And everybody should be well informed now that this is something that is very serious, that we have to pay attention to it. Otherwise, even though you're under Medicaid office, the heavy burden and blame comes to us, and that's automatic. So I think I always, believe in working together, will make a difference, and nothing's impossible if everybody's working together to achieve that goal. So again, I appreciate the full, report to us, so that everybody should be fully aware, and I hope the House are listening as well. So it's because it starts down there, and we'll do our very best to find ways to make sure that we don't lose out on that, and we continue to assist our people.
Thank you.
Thank you, and everybody that the panelists, I really appreciate coming over to to respond to the chairman's call and the committee, and I think the people in the gallery that are listening, they are the witness of what has already been been put on the table. So I hope that everything is going to be just okay. Thank you, Mr. President.
If you don't mind,
To I know that you want to say something, but
Yeah.
but let me ask for forgiveness to Senator Calvo, who's been trying to say something. So I want to recognize Senator Calvo, who's participating on Rhoda via Zoom here. So Senator Calvo, you're recognized at this point.
Chairman Manglonia, thank you so much. And just listening in to the importance of this committee meeting is very, very critical, very important. I thank the three presenters that are the invites for today, Dr. Chelsea Cabrera, who did share and discuss the nursing home situation. If I may, I've just recently experienced passing of a family member in the state of Oregon. And you as a senator and going through the motions to better understand the healthcare system and how critically important it is, You know, when you guys mentioned the home provision, there's so many facets in regards to, for example, my mother had open heart surgery. After open heart surgery, like, you know, the doctor's order required, you know, professionals to come to the home environment. That's my first exposure in better understanding the home outreach program, you know, that is in place. And it goes to show I'm not, you know, so familiar with what do we have in the CNMI and is it working? You know, I love the thought that you are the subject matter experts. You know, George Cruz with his testimony and advocating for the local match of 17, you know, down to the 17 cents versus the federal 83 cents. You know, that advocacy is critical. You know, and I love the thought of the proactive approach. You know, the circle of life is just around the corner. Let's not wait until like we are in the Manamco stage or we are critically ill to better understand the needs of you know what is at stake. So you know that 7%, the 9% decrease, we need to revisit that as a systemic you know part of funding. You know, just like tourism, you know, it's everybody's business. Medical healthcare is everybody's business. How can we continue to provide for our people, return, you know, that investment? And it goes, you know, in entrepreneurship aspects, we are becoming more of a liability rather than, you know, an asset. So I really like that statement that the director of Medicaid shared. I mean, he was hitting just bullet points left to right, and that's years, Chairman, that's years of service. You know, these are the key things and elements, and going back to, you know, commending our those who have the medical you know bills like Senator Karina. If I may, I'm jumping around, but if I may share this amendment, you know, anybody in the medical profession, they all have to speak the same language, whether they're a non-emergency, emergency, like me, Senator Calvo, former public school system. There are certain requirements when you have children in the classroom, first aid, CPR, how to handle children. You know, these are standardized things. So I really thank her for this bill to kind of like open the doors of continued discussion and regularly what are the things that work in the Commonwealth, what are the programs I think Dr. Chelsea mentioned in what Samoa. Okay, this is working in Samoa. How can we benefit from this? Okay, what are the grants and programs in place? You know, so we can, you know, not reinvent the wheel, but what works. We definitely have a lot of Senator Manny stayed in Oregon, so we have discussions. We do have a lot of healthcare providers in the mainland that are exposed, that know how to operate and open up, you know, healthcare facilities. They've been there for many years that can help guide with other professionals in implementing what they have. It doesn't mean that we don't have it, but how can we, just like the bills say, how can we have a more robust program in place? And with all three of your advocacies and the testimonies in front, you know, I do support this bill because it's that bar, setting that standard for the Commonwealth, saying, hey, wake up. You know, we cannot afford not to shortchange you know, the medical funding source and the care that we need to provide for our people. And I'm exploring too the different programs in place that we have for the Commonwealth, you know, for special ed, independent living, and these other federal programs that are in place. What more can we add to it, not take away? So I thank again, commend our Vice President Magofnia for this bill that opens the door to other bills that were proposed that we need, and the testimonies prior to the presentation, the ones that, you know, are true stories that we need to listen to, and we need to, you know, see how can we fix. It's not an overnight fix, but progress over time. So thank you, Chairman. Thank you to all our presenters. Thank you to the people that come before us for the testimonies. this is valued information and it affects us all. I really appreciate it. Thank you, Chair.
Thank you, Senator Ron, for your comments. Jesus Mosi. Now, getting back to our Medicaid director, let me just ask you, assuming that the matching is not an issue, how do we go about this? Does it affect the present Medicaid allotment for the CNMI, or do we have to change the state plan? Can you comment on that?
Sure. So yes to all of it, pretty much. I mean, if we have the funding, like I mentioned before in my last time here in the joint committee, our state plan is very dated. It's really very dated. Again, it was developed back in 2000. It was sparingly updated for certain things just to meet certain requirements such as COVID. But in regards to services, it really needs to be changed. And so this is something that we have been doing, especially I've been there for a year now at CMA, at the Medicaid agency. And so policy was definitely one of my priorities, is what are the certain things, the low-hanging fruits that we can change right away. And so we've been working with CMS to ensure, one, that we're following the law. And of course, in regards to the state plan, because the state plan itself is the contract with the federal government. And so they're very particular with that as in whatever is stated in there, we cannot veer off. But there are some wordings in there where it allowed some flexibility. Hence, we were able to put together some administrative directives internally that came from my office that allowed for some services to be implemented. As an example, we were able to finally cover podiatry services because of some wordings that were in the state plan that gave me that flexibility, and we got that reconfirmed by CMS to say, yes, you can. And so we were able to now implement podiatry services, which was never been covered in our state plan since we started. And so there's many others that we are slowly getting there, and it's just because policies itself, working with CMS, just working with the federal government many times, just their response getting back to us takes time.
But doing a major investment like nursing home, for example, is that something you can just tweak like you did with podiatry services?
No, unfortunately, that one is going to require certain spas and policies in order for us to get, to implement it, because it's something that's new and it wasn't part of our state plan. So if it's something that's new, that's not totally part of their state plans, we have to go through a process. And it's good to know that with Dr. Cabrera, also with CAC and others in the community, I think it's possible to be able to achieve it. Again, getting the local matching. And again, this is in line also
how does that work with coordinating with the VA, for example? There was, recommendation that such facility, if coordinated with the needs for the VAs, that, you can actually make it feasible. How does Medicaid work with VA?
They're two totally separate programs, federal programs. And unfortunately, if something is covered under VA, for veterans, it's most of the time not covered by Medicaid because it's already a full benefit covered by VA. But those are things that we can get more clarity and clarification on as we move forward. But again,
a VA facility doesn't need a change in the Medicaid state plan, right?
No, VA can do what the VA wants to do. Yeah, it's
but
very
they can do facility, right?
From my understanding, again, the fundings are very separate in regards to that.
I think we have Joe Chrysostom in the back, right? Yeah, you're welcome to please come and join us. I just want to get to understand, the members to understand more. Joe, can you introduce yourself? I haven't met you. This is the first time, and so can you?
Yeah, my name is Executive Officer Jose Crisostomo. I'm the Veterans Affairs. I'm in charge of Veteran Affairs. To summarize all, the VA is very unique because they have their own hospital, they have their own home for the what do you call it, caregiver and aid and attendance, and they pay for them. I hate to say this, but a nursing home is a state program. It's supposed to be run by a state. You can try to get with the federal government and find out how you can get assistance to, like the Medicaid, probably a matching fund. But the VA, when we process for a caregiver and gets approved, that caregiver gets paid by the VA to do their caregiving thing, even aid and attendance. It's different for a state. I don't know who's the approving authority for a state to approve a caregiver for a patient. I don't know if we have that program here in the CNMI.
You answer that, Director? Can you answer that question? Who's the authority here to?
Oh, that's a insurance and payment issue.
But for those
for
like,
the VA, what he's saying specifically is, so for their VA benefits, one of the benefits is that if you have a caregiver, the federal government under the VA program will pay for it. One of the things that Dr. Cabrera mentioned is and Senator Magofnia was asking was, do we have a program like that? And it's not. We have small versions such as the respite care and caregiver, and that's really on the assistance for the caregivers. But as far as a payment program, Director Cruz just mentioned also, that's something when it does come about will be needed to be amended and added to the state.
You know, what's their name? Nursing home, right?
Yes.
I mean, nursing care, skilled nursing services.
Yeah.
Who approves those services for payment? Medicaid pays for those?
Everything is insurance based. So if they're Medicare certified, they have their own criteria. If they're Medicaid certified, we have our criteria. If they apply with Aetna, they have their own criteria. So each insurance company or provider has their own criterias on what needs to be met in order for those services to be paid, to be reimbursed.
Okay.
So as an example, Senator, so for home health, you don't need to be Medicare certified, but if you're not Medicare certified, you can't treat Medicare beneficiaries. You can't get reimbursed.
Okay.
You can treat those with Aetna, you can treat those with Moylan's, self-pay, but each of the payers, which are the Medicaid or the insurance providers, they have their own determinations and criteria.
So maybe I should ask: do you have data? Anybody have data on how many of our residents are qualified for Medicaid, Medicare, or VA, or for these federal?
I mean, what we can provide you is how many beneficiaries we have registered, but in regards to how many qualify, it's the criteria. It really depends until they come in. But with Medicare, typically the 4 requirements for Medicare are you've been disabled for at least 2 years, you have Lou Gehrig's disease, or you're 65 years or older, or you have ESRD. So if you meet one of those criteria, you may, and I want to stress the word may, qualify for Medicare. So every insurance company has their criteria. So it's not a blanket that covers everybody. It's Medicare has their own, Medicaid, etc.
Okay, and let me get back to Joe. Joe, do we have people in VA veterans here in the cinema in need of the services described by the director and Dr. Chelsea? And
yeah, we got a couple of veterans that they have approved by the VA. They're like aid and attendance, and that person is main responsibility is to aid and attend for that veteran, and they get paid for that. I don't know the state, like you said, probably the insurance have to pay for there, but I do know that the veteran, like I said, it takes care of itself, that they have a program, like I said, they have a nursing home. So if you're if you have no family, they have a, like near a veteran hospital, they'll have a veterans home that once they release them from the hospital, they go directly over to the nursing home to be taken care of by nursing what do you call that, personnel. And it's very unique because, you know, the only federal hospitals that I know of that is run by the federal government is the military and the veteran and the VA. It's federal funded. And from what I know is that any other state, other than if they don't have no military base or a veteran hospital, the state is responsible for, you know, and I don't know if you guys are aware, but majority of the hospitals in the states are not government run. They're privately run, like a corporation. You might want to look into that, you know, and try to learn how we're going to, because I know for us it's a state run, right? CHAC is under the government, even though it's a corporation, but it's under, still we subsidize them. And the same thing with the hospitals in the States, you know, they get subsidized too from like Medicaid and Medicare, whoever goes to their hospital. It's just kind of unique that, you know, we're not really, I know we're hurting on our economy, but from what I know is that for us, the CNMI, we run a hospital ever since we were during TT, if I'm not mistaken. Everything is taken care of. In the States, it's either you're under Medicare, Medicaid, or you have insurance. And I'm pretty sure it's the same thing over here. But it's just like for the VA, like I said, we, you know, the VA takes care of all their veterans. And maybe we can learn from their operation, how they, because they run their own pharmacy too. We mentioned earlier about pharmacies. You know, they run their own pharmacy. And what they do is they mail, if you prescribe a medication, it's on your file with the VA that these are the medication. You go on the website, you click on it, and it will pop up when it's getting ready for your next review. And all you gotta do is log on and click on them, and it comes in the mail.
Thank you, Joe. I just want to go back, Fan, to the issue of this long-term care facility now. And I want to ask Dr. Chelsea, because I remember we had discussion with our legal counsel on coming up with a legislation, because it was pointed out that a regulatory body is required. Can you elaborate more on that?
Yes. So CMS requires that states and territories establish a legal or regulatory framework designating an oversight authority that's responsible for the licensing, the inspections, the certifications, and the compliance when it comes to these nursing facilities. And Director Cruz, if you want to chime in on that.
Yeah, no, actually, that's in line. That's correct. And again, I just want us to make this clear in regards to the long-term care facilities. Medicaid is just one funding source, right? It's a major funding source, but it's not the only one. There's Medicare. There's also private. Some private insurances cover, and there's also self-pay, right? If you look at Guam as an example, or Hawaii, a lot of patients who are in long care facilities, they assign their Social Security benefits, their retirement benefits directly to the facility as part of their payment for being taken care of. So there's so many different things. So I'm here to say that Medicaid is in support of the long-term care process, because it helps with our healthcare system, our healthcare cycle. It's very important. But in regards to Medicaid to be able to fund it, moving forward, there has to be that matching fund in order for us to start utilizing or to be able to utilize federal funds to cover that type of service for us. So I just want to make that clear. We're in support of having the service, but funding wise at this moment, we're not able to cover any of those services.
How many patients are you looking at? How many do you feel we need in the CNMI that are in need of this nursing?
Well, at least from when I was in my previous life at Marinus Health, when I was there, we had on average a minimum of at least a dozen patients who were homebound or bedbound. And we experienced families, patients who were being abandoned, and we're talking local families, both Chamorro, Carolinian, who were being abandoned by their families, literally living in barracks, things like that. And so the need for long-term care services such as a nursing home or some sort of facility like that is definitely needed here. Our culture is changing. Times are changing. Society is changing. Economy is now the issue versus, taking care of our Manomco. And that's the reality of what's going on outside of these walls. Once people get discharged from the hospital, I know one of the questions, do you have your medications? Of course, yes. But when they leave, they can't afford their medications. They can't afford their copays. They can't afford, medical supplies. And so when we go into the homes, patients with wound care, these are not the sites that we want our local people to be in. And I mean, we find families, literally patients in their own urine and feces because they have no one to change them for weeks.
Senator Corina?
Thank you, Senator Bowen. This is very sad to know that we have come to this point in our society, which we've never heard of, in the history of the Commonwealth. But I do understand that, societies are changing, generations are changing, culture is changing, and the question is, what are we going to do about it, right? To help our Manomcus in those situations. Sorry, let me just kind of like.
Let me recognize that Dr. Chelsea, I think she wanted to
Yes.
jump in.
Yes, and I just want to echo Director Cruz's words. There is a gap in continuity of care from discharge and then what? And there's that shared burden with CHCC, with stakeholders, leadership, the governing body. So we have to find solutions to this. And when we talk about long-term care systems, there's two primary systems. There's assisted living and skilled nursing facilities, which are very two different levels of care. Yeah.
So the recommendation, where do we put this regulatory body?
Well, you can put them under the healthcare professional board licensing, create a subdivision, create a subdivision. Start with a small team and then expand when the demand expands, when the need expands. Yeah, but there is a need and there is a sense of urgency surrounding this.
Mr. Chairman, if I may, I think I hate to say, but it's probably it falls under the CHCC, the hospital, that to come up some kind of program and probably get our delegate King Hines get involved too for to get federal funded. But we have to come up with a plan on how we're gonna pursue this like a nursing home, how big it is, and they mentioned about Castro about buildings around here. We got a bunch of hotels here that are not occupied, and why don't we expand our hospital and put a nursing home there too, together with the main hospital? So they get discharged, they just move over to the nursing home. Canoa Resort, Mariana's resort. The buildings are falling apart because, Canoa Resort was used for during the COVID, right? It's already, some of that area is already fixed into like a medical facility. But it would take both houses of the Congress and the governor to make that happen with our delegate to request for federal funds. It doesn't hurt. And nursing home be just almost the same as like the food stamp program. You know, because of the low income that we have. Well, we don't have a nursing home. Majority of the states that are nursing home are run like a private, you know, and like I said before, majority of the hospitals are private hospitals that they what do you call that? They run it. They run. But I guess what I'm trying to say is, we have the facility. We just have to come up with some kind of plan how we're going to execute it, and the cost. So we'll know how much really. We got the experts here. We got all the information. Combine them all, but you have to create some kind of team to get together and say, hey, you got the medical, you got the social workers, because you're going to need them, because they're the ones that will determine if, yeah, they qualify. And the financier, who's going to finance it?
Other members wanted to ask, but let me go back to Senator Corina.
Thank you. Wow, so many things is running through my mind as I listen. But before I forget, I just want to thank the team who are here in support of Senate Bill 24-30, and I really do appreciate the input and feedback as to the recommended amendments that need to be made to the bill to improve it and to ensure that it's in compliance with federal regulations. So I will be reaching out to all the relevant stakeholders to ensure that we capture all those amendments in the bill before we do anything to it and take action. Second, we earlier there's some conversations about federal match, right? And thank you, Mr. Cruz, for providing us with that very powerful statement and why it's so important that we meet. The government meets its funding match to be able to continue to provide those programs that are very much needed by our people. But as we all know, funding is always an issue, but we need to start prioritizing. And as Senator Cruz has mentioned, it starts at the House, and then it comes up here. But we will definitely do our best to support in any way that we can, and while still trying to maintain the balance of everything else and trying to fund other departments, right, that are needed in our community. But going back to the federal match, so has there ever been a discussion between the hospital or the team with perhaps the administration, the governor, to take these types of issues and discuss it at the 902 consultation? I mean, there's nothing that stops them from asking for assistance and probably just even eliminating the state match, right? I mean, it's very little compared to the things that we are giving up. But again, it's always been in my practice to ask, right? Because the worst they could say is no. And I think if you can articulate it in such a way where you show the impact and the benefit of the recipients, right, for a minimal ask, I think we can successfully get some kind of assistance in that aspect. But I guess my question is, has this issue with the federal match or even just the nursing home been brought to the table with the governor to see if this is something that he could talk to his counterparts at the federal level, or maybe even our U.S. delegate? But I think the appropriate authority would be the governor.
Yeah, can't speak in regards to what they actually discussed just recently, but I know before the governor did leave, I did have discussions with the administration that in regards to this issue of the matching, especially during this economic time. And the thought that was brought out was possibly requesting that the 17% matching, local match, be waived. But again, whether that was actually discussed or not, I don't know. I will be meeting with the governor. I think it's today or tomorrow. And I'll definitely bring that up and see if that was brought to the table. But just to kind of just add, just to put it into a little bit more context. So just last fiscal year, we paid out Medicaid, we paid out over $127 million in reimbursements. But and out of the 127 million, 63% stayed locally. So that's about $80 million that we kept within the CNMI. In regards to $86 million that we kept in the CNMI. Now, one of the things I did bring up before, both on the House and the Senate side, was we were short 3.5 million in local matching. And so with that 3.5, we could have added an additional 20 to $22 million last fiscal year back into the local economy, right? But we were short that matching. And so just to give you another perspective, just since this fiscal year, from October 1st to the end of February, we already pumped in about $30 million just locally within the local economy. So it doesn't just go beyond the fact about, services, but we're also contributing to businesses and livelihoods here in the CNMI. And, as we think, because I don't know if you've heard, but I know the delegate is pushing to get our federal matching from 67 up to $97 million. And the reason being is we are the lowest federal matching in all the territories. American Samoa has more money than us, and yet we have the similar population, right? And the same thing with U.S. Virgin Islands. They have way more. They're at six figures. I mean, 3 digits, as in 100-some million, versus us at 67. So we're the lowest. And so, but one of the things that we discussed is, yes, we could do so much more of this 37 million additional, right? We could definitely do the long-term care. We can definitely do so much more services, especially preventive services, to keep our people, in regards to maintenance care rather than, again, crisis care. But it's going to come down again to the local matching. If we get that additional 37 million, our local matching is now going to be a little bit higher, right? It's going to probably be up to $15 million, right? And so that's going to be the question is it worth it to fight for that 37 if we're not able to get ourselves up to that local matching? Because at the end of the day, if we don't use it, we return it. And so again, like I said in my one of my testimonies, is we can't keep asking for more, which the federal government is willing to, if we can't put in our share. And I know you guys that's the most difficult part for you guys. But I just wanted to share that reality with you guys. That's how much we're able to contribute into the local economy while we're also improving healthcare services here in the CNMI.
Chair, just one last comment. And thank you for pointing that out. I know that funding is scarce, right? And we know that. But for me, I think it boils down to priority, right? What are the government's priorities? We do identify, funds from different sources, for example, at the SNIOT level. And this is not to throw SNIOT under the bus in any way, but we do appropriate a lot of funds to different nonprofit organizations. And this is not to say that those nonprofit organizations are not helping our community, right? Because they do. So when we are backed against the wall and have these very limited resources to work with, we have to make those hard decisions and we have to prioritize, right? And so if we were short a little bit over $3 million to fund the match, right, to be able to get an additional 30 plus million. There is no mathematical logic that that we could deduce from that. It's very common sense that we could have, right? The legislature as a whole, or even the government, central government, could have provided that 3 million to gain the 30 plus million dollars that would have been circulated in our economy. And so, you know, I'm just one of the 29 members, and at the SNIOT, I'm one of the 20. But I would encourage you guys to continue to come and advocate and lobby at the SNIOT level, because, you know, in a year's time, I'm pretty sure we can collect or, set aside a little bit over $3 million to be able to provide that matching to Medicaid, so that we can continue to provide those very needed and critical services to our people, most especially our Manamku, who are in those really bad situations. So I will continue to support and advocate the needs of the programs that you guys are providing to our people, and I'm sure my colleagues also feel the same way, but just different priorities. So I will keep that in mind at every appropriation time during SNIOT, and I really would like to continue to ask you guys to continue to ask funding assistance from the SNIOT, because there are funds there. We just need to prioritize. So that's all I have, Chair. Thank you.
Before I recognize other members, Director, this is related but a side issue. Maybe you should give some recommendation to the legislature on revenues that can be earmarked annually toward matching, because there are revenues that are made related to health services that we can actually earmark so that they don't fall under the regular general revenue funding, and we appreciate if you can look into that. Senator Manny, then Senator Cruz has been raising his hand. Thank you.
I just wanted to, thank Director Crisostomo for talking about the Canoa Resort. In a prior meeting with Dr. Chelsea, we talked about that, how, we use our asset to cover our liabilities. And Canoa Resort is an asset, and a lot of federal funding went into making it an alternative care site. And, might as well use that federal government, or actually it wasn't reimbursed, so or the local government's investment into making it an alternative care site. But Senator Karina also brought up the delegation, and I share that sentiment. It's something that I also repeated, is infrastructure and assets, right? For our people that get medically referred, it's probably easier for the delegation to buy a condo or apartment or hotel, and public-private partnership run it, so that when we send our people for medical referral, we have an asset there in the Philippines that can reduce costs and improve outcomes. We just have to think outside of the box, right? Like, so Canoa Resort, we have Philippine Airlines coming in. A big part of that is, we have a pretty good dialysis center at the hospital. That can be a dialysis center, not only for the tourists coming in because it's already a hotel, but one of those towers can also serve the liaison office, because the delegation, like Saipan delegation, Tinian delegation, Rhoda delegation, they build assets which are helping them reduce the cost, but we can always expand, right? And synergize. And I like this synergy right now, because we have a lot of solutions, but we need to ink it, but we need your help. We also need your help because, like Senator Karina said, there's a lot of us, and we, when it comes down to prioritizing resources, all this public comment and evidence and data, it makes an impact in in that process. So again, I do thank you for your time and all the hard work that's and especially for a lot of you that came back, those that served. Mr. Crisostomo, the VA is probably the biggest federal agency in the United States government, so a lot of resources there. But yeah, there's a lot we can learn, both positive but also mistakes that agencies have made that we can prevent from repeating. Thank you again.
Thank you, Chairman. And Director, this is to clarify. If you mentioned it earlier, I apologize. The nursing home that Dr. Cabrera was in regards to the bill, just the same as the hospital, right? Medicaid cover Medicaid recipient, right? At the hospital. So you can cover, right? Also the nursing home?
If it's part of our state plan, yes.
Okay. But provided matching, right?
Yes, and that too, yes.
Okay. And I appreciate that because, I think this is on another way of, making that reality, in nursing home. And back to I know we keep on jumping from miscellaneous to the bill, but I think the chairman is not paying attention, so I can just go ahead and because we've been we're under the miscellaneous, then we jump to the Mr. Chairman. Never mind. So those at the dialysis that are non-US, do Medicaid cover for those? I wish, no offense to non-US, I wish they can cover everybody because we're all human beings, but maybe laws are low, right? On eligibility, right? Especially federal government. I hope the federal government can be able to, to allow that. But if not, then does Medicaid cover those?
There's been a lot of changes with the OBA law. And one of the main things with that was also in regards to immigration status. And so those are some of the things we're working through right now with our national partners to ensure. One of the things that we are sure of is that all of our COFA residents are exempted from that law. So that means they're still covered.
Still covered?
Correct.
That's what I want to hear. Because I don't want CHC to be burdened with everything, that, right? Used to be CHC paying for that. I think $1 million every year, right?
Yeah, and
so now it's covered.
What Director Cruz is talking about is COFA residents, and I think you're talking about specifically like non-US
yes.
Citizens. But that is something, again, as Director Cruz had mentioned, it's not part of Medicaid, but he's talking about the COFA citizens.
Yeah, that's why I'm asking if it's not Medicaid recipient, are those?
So COFA, I guess.
I was informed because we entertain public hearing for CAC governing board, and I was at that time we were informed that it's already covered by Medicaid. I'm not sure whether.
So I think there's two because COFA are related to FSM, Republic of Palau.
Yeah, I think FSMs are covered, right?
Yes, correct.
I'm talking about
this is the uncompensated non-immigration status.
Those are different.
Correct.
I'm talking about from other different countries that are not. Are they covered? No. So CHC still continue to pay for those?
Yes.
The same thing I mentioned earlier. I addressed that too. That I think this one have to be addressed to just seek guidance, legal guidance from the AG as to how we can, or maybe the administration can work out with which government which country they're coming from, so that government to government, just similar to FSM, right? Where we're giving the compact impact funds just to cover those, right? So I think in that regard should be the same thing as any other nation, that comes here. Like I mentioned, no country, I believe no country is allowed to abandon their own national, any foreign country, including us, right? So those are the things that I raise, and I hope that they take that seriously to address those, so that we like I mentioned earlier, I hope everybody is qualified, no, because we're all human beings. But if we're not, even the federal government, they have restriction on eligibility. So I think we should look into that, so that CHC will not continue to burden. I even mentioned that to the governing board, and I don't know whether that's many years back. I don't know whether they're taking that seriously, but something that we can address it. For me, we got nothing to lose. We're going to lose more if we don't address it, because we keep spending. You know, we have consulate, China, Chinese, what's that, embassy. We have Philippine consulate. We have whatever representative that are here in our area. We should, you know, but it has to come from you guys, because we cannot initiate that, because we are not the one receiving those patients. If we can address it, but they're gonna say why CAC is not addressing it. So, you know, it has to be the proper agency to initiate and then maybe perhaps if the Attorney General or other government agency did not you know follow up on that, maybe the legislature can also follow on those matters, or through our delegates. But if we leave that idle, we continue to incur those. CRC will be burdened with the cost. So, like I said, I wish everybody should know, we can qualify everybody, but even with the federal government, they have the guidelines, they have the rules. So I think we should do the similar thing, no? So that it's not that we don't care for this human being, but the thing is we lack like even with Medicaid, we still have. And I want to ask, how much exactly moving forward do Medicaid needs to match the federal government?
Right now, at the funding source we're at, approximately between
9 to 11. No, but you mentioned earlier about an additional 30. Huh?
That was from last fiscal year. I was just mentioning that. I just want to put what you were saying in context about the importance of matching.
Okay.
So again, from the last fiscal year, I mean, even though we were very successful at, reimbursing over 127 million, because we were short on that matching of 3.5, which I was trying to find from the legislature and the governor's office, we were not able to pump in an additional 20-some million.
So we need 9 to 11 million.
Correct.
Including additional. This is to include the additional.
No.
Applicants.
That's for everything right now. Now, if
for
we
what
get
we
the
have,
if
what
we
we-
go from 67
So
to 97
you're talking
million,
about only the recipient that we have now. This is 9 to 11 million.
yes.
But you know that you're anticipating more, right?
Well, because that funding is based on what our current federal funding is.
Okay.
So, again, that's what I was mentioning. If our Congresswoman, our U.S. delegate, is successful at increasing our federal share from 67 to 97, that's going to increase to approximately almost $15 million for our matching.
Okay.
Right. So that's where we're at right now at 67. Plus, we have other COFA funding and CHIP funding, which require all matching.
Okay.
We need between 9 to 11 for a full local match. If we're able to do that, we can maximize every single penny of our federal resources.
Thank you for that. And Mr. Chairman, because you didn't, I was saying something about jumping from miscellaneous to the bill. If we're done with the bill, can we?
Well, I think there are other members still. One more. Then I have several questions.
No,
So
if we're done with the bill, can we go back to the miscellaneous?
yeah,
Because I'm confused also which one
we're just on miscellaneous
we're
part.
still miscellaneous. Okay, so that's good. Can I'm not done. Can I have one
Okay, can we give you another minute or two so we can move on?
Sure.
I
more? No,
think
in regards to health network, because I understand you can speak on health network, right?
Actually, I have the health network program team is here. Yeah.
Thank you for joining us, Tiffany.
Thank you, Mr. Chairman, for giving me another just 2 minutes, right? You said. Thank you, thank you. I think 2 minutes is enough because this is not a long question. In regards to help
Can
me-
you
I know-
turn on your speaker, Senator? So,
It's on.
oh, okay.
I understand there's also eligibility on the medical referral, health network, the from medical referral to health network. But in the event, I just want to find out because some concerns comes into my attention that those that are not eligible, how do they go about when in coordinating the other end of the, for example, they send to foreign country. Like I know that there's a lot sending to Korea, no? Do you guys assist them in coordinating the receiving doctors? Because for me, I think health should be doing that because you have all the record, right? And I learned that for Aetna, you don't health network does not get involved with Aetna insurance. Can you elaborate on?
So the question is for those not qualified under the medical referral program, what assistance do you give to assist these patients, right? Going to Philippines or Korea and other places, Chairman? Is that the question?
Yeah, to foreign country. Because I just learned that if you're not eligible, then you do your own, right? Can health network coordinate the receiving doctor because some patients don't know how to go about with the coordination of the doctor and the other end.
Yes, we can. Hello everyone, my name is Carmen Lizama from the HNP. We do assist patients if they're not eligible with the income criteria. If they have private insurance, we coordinate with their private insurance, to see what foreign places are in their insurance plans. And we do assist with like gathering the records, referral letter, and getting an accepting physician.
So you assist them to, even though they're not eligible for medical health network, to process to process ticket or room and board, blah blah blah. But my concern here is the doctor that are going to receive the patient. Do you guys give any guidance to the patient as to how they go about with it? Because most of the people here, they kind of like confused how to do that. So can this health network be providing at least that kind of service, even though they're not eligible to be given airplane ticket, room on board, transportation? At least the medical doctor that will receive and maybe perhaps make an appointment for this patient if the patient is willing to go and get seek medical assistance in a foreign country. And I understand because we spoke with the CEO that I think remove Philippines in this regards because I don't know, we were looking to help our citizen for a further medical assistance that is affordable. So we've been having good relationship with Philippines, right? I don't know why all of a sudden Philippines is out of the picture and only Korea. So can you elaborate more as to why remove Philippines from the medical service?
Yes, so thank you, Senator Cruz. Tiffany Crisostomo, for those who don't know me. So yes, like Carmen mentioned, we do help coordinate appointments at Samsung or the hospital of choice that the patients decide to go to. So with Aetna specifically, we are actually working with, for example, Samsung Hospital in Korea and collaborating with Aetna on how to make that process easier. We're talking about having like pre-visit consultations before the patients leave here so that Samsung can let them know, how to proceed with their visit or even to see if they're eligible for the procedure that they're being referred to. As far as the Philippines, it's really at the end of the day up to the patient where they want to go. So if they choose to go to the Philippines, then there is that coordination that we can help make appointments for. And we do have contacts at, for example, St. Luke's, that we can reach out to for them if they don't know. There's been some, for example, like patients who are visiting in the Philippines that are receiving dialysis, for example. So those are the types of things that we can help with.
So in regards to Philippines, why Philippines is removed from sending patients to the Philippines? What happened? And some of our residents, you know, they've been going to that medical institution because it's for them, it's affordable and they're comfortable, and it's, you know, it's not that compare. No offense to you, but it's so far, and if they're not eligible, then most of them, they cannot afford to even buy a plane ticket to go, and especially if they don't have family in that area. But the cinema and Philippines and Korea are very short distance, no? They can, but why remove Philippines and allow Korea?
So Philippines wasn't necessarily removed. It's up to the patients and where they want to go and what insurance the facility accepts. So, for example, in Korea, Samsung Hospital, they accept the our Aetna plans. St. Luke's in Philippines, yes, they do. So it's up to them. If they want to go to Philippines, they can go there.
Those that are eligible, they're sending to Korea, but they don't send to Philippines anymore? Why?
I guess I'm not. I don't understand.
Maybe the CEO can answer to that?
No, I'm sorry. So it's up to the patient.
Oh, you under the CEO?
Yes, we all are. And again, my name is Helena Palacios, and I can yield to the HNP program. Reiterating what CEO Tiffany is mentioning, again, it is up to the patient. There's nobody saying you absolutely can't go to the Philippines. What I will say we have encountered is that the specialist that a patient may need may be different from 5 years ago, and that's not available in the Philippines. And there also has been a history and of billings and medical expenses that have not been paid. So some of the places that before, maybe 10, 15 years ago in the Philippines, that openly accepted our patients when they were covered through medical referral, even if they didn't have insurance, are not doors that are open anymore. You could qualify for the health network program currently, but again, if you don't have insurance, that again closes the door for where you can go and receive services. We have that's the same thing as facilities in Hawaii. A lot of also our patients, I'll give an example, that experience oral cancer. You'll hear that a lot of them do go to seek services in California, and that is also where our patients who may not, whether they are insured or underinsured, can also avail of social services from those states or those areas that cover the bills that we're not able to, not HNP alone, nor the CNMI government. So it also becomes this plan for where the patient can go get services, and also it is financially it is financially responsible for us to send them as well as the patient. But I will yield to Ms.
I don't have any problem with the U.S. mainland. I'm talking about these two.
Yeah, the Philippines is
I hope
not.
there's no problem between our doctor and the doctors in the Philippines.
No, there's not. Again, as Ms. Tiffany mentioned, it really is up to the patient. So if the patient doesn't have any insurance and says, I want to go to St. Luke's or Asia Pacific, we can make the appointments for them, but are we going to walk them step by step the way it was 15 years ago? 15 years ago, we also had offices in those places, and the HNP network has really worked to consolidate the cost that it does to run the program. And you've seen that, whether it's minimizing our staff even in the CONUS, and just really trying to work more efficiently with partners that are opening their doors internationally. So I don't know how else to answer your question,
Okay.
but I can
Never
note
mind, we don't
to.
wanna prolong because he only
Yeah.
gave me 2 minutes, but I went beyond that one. So you take care of, you guys take care, even though they're not eligible, even with the what's that, the insurance provider, you contact the insurance to make sure that if the patient is willing to go, right? Of course, if not, you don't have to waste your time. But I'm just looking for ways to to help our people that can only afford this area, because if they're not eligible, I don't think they can afford to, even though they're not eligible. The income here is different from the income back in the mainland. So I don't know why we have to. I think that one needs to be reevaluated because the cost of living here is very high. And if you base on, I heard that it's if you're earning 39,000, just remember that you don't get the whole 39, right? You go to the net. So I think that needs to be reevaluated and see how we can help our people. Huh? I appreciate your your patient and cooperation, and I'm sorry because the CEO is not here, but I think you're the acting right now, right? So I appreciate your also no patient, no. And Mr. Chairman, I apologize. I know that you're not going to
Thank
give
you.
another. Oh, I'm done for today.
Thank you, Chairman. And so I guess you understand the concern, right, by the Chairman. I think he has emphasized in detail his concern. Senator Manny?
I'll just keep this short, but two experiences. Thank you for sharing all those. Thank you for the team for looking into reducing costs but improving outcomes. I could say from experience that my late grandfather, when he was referred, I would always question why are we sending him to Hawaii and his appointment, the doctor is on vacation. So we end up just paying for hotel that we don't, that money that we save, we can divert it somewhere else. But and to summarize kind of what was being brought up by Senator Cruz, like, as long as we can continue to do things like that and synergize, I think a lot more counseling with the people that are dealing with the patients to make them understand, like, the program has changed and also, like, just, it's not just CHC. We need a lot of work in our government in terms of social services and how to deal with customer experience. There's a difference between, in the business side, they call customers, but stakeholders, clients, and there's a way to deal with them. And it's sometimes when we work in the government, we don't have that. We're too busy. We can be stuck in silos, and we can, we don't know what people are going through, and so Senator Cruz just got raw. He's, the person that called him probably is really raw and complaining, and he has to, he still has to do his job and try to advocate for that constituent that was calling him. But in light is, I think that's where we also need to make sure that from the service perspective, we go from, instead of customer service, I'm sorry, this is all we offer, here's a gift card, to customer experience. Oh, nandinang, how was your medical referral last time? What can we improve? And knowing the clients, looking at the data, and I know we have a lot of capable people that, but sometimes we just are very stressed, and that's what happens when the economy is like this, where we have to deal with a lot more things on the plate. But CMS, and we have all those standards we have to make sure that we're meeting in order to get the funding. So let's continue to do that. And thank you so much.
Thank you. I appreciate everyone's presence up to now. It's already 12:30, but I just want to move some of the concerns along. Dr. Chelsea, let me just go back. I want to go back to health network programs, but for now, Dr. Chelsea, we're clear on on the regulatory legislation. We're gonna work on that. We need that, and in order to regulate long-term care, right?
Yes, and I just want to disclose that I've had premature conversations with the chairman of the Senate, JP Sablan, Congressman JP Sablan, and he's in full support of this system. So we can work collaboratively with CMA, CHCC, and other stakeholders involved and get the ball rolling on that. But you know, the CNMI has a very unique opportunity to position themselves as a destination hub in the Micronesia for end-of-life care and long-term care. And it's another aspect of tourism, medical tourism, that we can tap into, you know, to increase our revenue, right? So I say this with confidence because the CNMI is composed of skilled leaders, critical thinkers, and innovators. And then there's also that pressure from Guam too for the CNMI to get the ball rolling on this. So thank you.
And Director George, to change the plan to incorporate such facility, to have these facilities here, how long does it take? I mean, assuming that they tackle this matching issue, how is it a difficult thing to? Do you visit it every year now? I mean, once a year. Other than those simple state plan changes that you say you are actually authorized to do for some major undertaking like this, how long would it take?
We're on policy every month. Every week we have a meeting regarding that. But the shortest we've seen is 3 months. The longest we've seen is 12 months. So again, it really depends on CMS and the back and forth negotiation between the CMA and CMS.
And then you mentioned, thank you for that, and you mentioned also matching concerns. Have we actually lost federal matching share because of the, and what's the average that we lose?
A lot.
We lost.
Again, one of the things I stated before is there's never been a time that the CMA has been fully matched. There's never been a fiscal year that we've been matched at full funds. So again, that's just this past 3 years. I think fiscal year 24 it was 7 million, and so it's been going down. Fiscal year 25 it went down to 6 point some million, and then of course we're at 5.8 million this fiscal year.
That we did not match?
Well, that's what we've been budgeted. And so, of course, you minus that from the average of 10 million, we're always short about between $4 to $5 million.
So it's not an issue of competing interests as far as changing the Medicaid state plan because it's going to eat onto other programs.
Correct.
It's just a matter of trying to get that matching. Once you get that, all the other programs, they're not fighting, right, for to go against any state plan changes?
Well, every new service that we provide does cost something, and so the only reason, and so that's why we're also hoping to get the increase from the federal side from 67 to 97, because in that way we can do a lot more. I think we can definitely support CAC a lot more in regards to both even their uncompensated care. We can do so much more in regards to long-term care, the MFP, the HCSBS. There's so much more that we can do that are cost-effective and can help our people. But again, it's because of that matching. So everything, these are going to be all new programs. So all of the stuff that we're currently doing, which includes supporting CHC and everything, even off-island, pretty much consume our whole 60s, all of our funding. And so, and it eats it even more because we don't have the local match, right? And so we're always short every year.
Yeah.
We're always short every year.
Okay. One other side question on Medicaid. Guam, maybe I'm not understanding it, but Guam's patients can go to the Philippines and Medicaid can cover them, but not the CNMI. Can you explain further on that?
And that's actually what we're working on is our SPA, our state plan amendment. That's never been a part of our state plan. And so that's part of the things we're working on. So,
but Guam actually gets covered in the Philippines?
Yes. And so does American Samoa. They go to New Zealand. in
So what are we doing there, and how far are we away from that?
We are in that process right now with CMS and submitting our SPA, our state plan amendment to them to hopefully include that as part of our state plan. So that's in the process right now. Unfortunately, it took us a little bit longer than we expected. I was hoping to get that completed by July of last year, but yeah, unfortunately things have happened.
Well, I bring that up because I think I did mention this to you before about in Guam, if you are 65 years old and above and you are a retiree, or let me get that straight. If you are Medicare, right? Medicare, if you are Medicare, under Medicare, you're 65 and above, Medicare covers 85% or 80%, and your Aetna, your insurance, whatever, covers 20%, right?
Correct.
So that patient, if they go to the Philippines, it doesn't work if Medicare also gets covered in the Philippines in Guam?
No.
No, not for Medicare.
Correct.
Okay, so just Medicaid. Huh?
Medicaid and some other insurances such as Aetna, Moylan's, Calvo's, other local.
So if they're covered in the Philippines, it makes sense that, for example, Health Network program sends them to the Philippines, right?
Yeah, it's very, very cost effective for any foreign providers.
Okay. Okay, pues, Senator Castro?
And there's also a recent bill that allows foreign providers to practice here in the CNMI that was passed as law. That was your bill, no? Or Senator Donald. So again, that's leverage to help our economy that was mentioned earlier. Like some of those, so that way, for example, just like what's on Guam, like with the regional medical city, like just get more. It doesn't have to be a big one. It can be small clinics that alleviate the stress on the hospital. But at the same time, sometimes the mindset is like, oh, we're gonna lose revenue, right? But I think we should also look at like the cost savings and also the lives that we can, the sooner they get the information, and even things like the like blood work and all those things that we have to send off island to Hawaii, and sometimes it takes like 3 days by the time, instead of really investing in our own lab here, so we don't have to send those specimens so far away. Like, invest in the asset, right? Like, that could save lives too. I know a lot of people close to me that have passed away. By the time the results came back, they're gone. Like jungle juice of IVs, and they're maxed out. So things like, we have to think, what are the main costs and how can we alleviate, and time is money, data is money. Look at the data and see, like, just maybe not same thing in Guam, like not in the health field, but the crime lab. They invested in a good crime lab, and they don't have a lot of unsolved mysteries there compared to us, because they invested in the lab, right? So the data is all there. Let's continue to work and make it happen. And I just want to commend all of you guys, and especially with the state plan, because when I met with the Medicaid state director for American Samoa, like maybe 2 years ago, and in American Samoa, they don't have it. And everybody's on Medicaid, right? So we're lucky here, like, that the government is also prioritizing this kind of insurance for the retirees and the employees, and then we are also lucky we have Medicaid. But let's continue to look at our plan to improve it. Yes, Philippines is a good option because of the cost savings, but also I know that staff on the CHC side have been visiting different hospitals, and we have to look at also infrastructure. When the patient gets there, how's the flow from the airport to the hospital? Is it smooth? Do we have, because I could share, I haven't been to Korea for health purposes. I've been a patient at Asian Medical Center in the Philippines, and lucky I chose during my time when I was still at the college. I've been going to the clinics and the hospital here, and they just told me that, it's just they just keep giving me antibiotics. And then when I went to the Philippines and got checked, I was in the Philippines just for vacation, but I decided, I'm here, might as well spend a little bit of money, and since the insurance is covered, let me just get a checkup. And oh my God, it was a tumor and a very high malignancy rate that the doctors we need to remove this. Right, that was in 2009. So I do support this modifying the state plan, because sometimes when a hospital is stressed, and that's our work too here. We need to find ways to help this system. But in the meantime, we just need more options. Just more options. I'm not gonna say which colleague, but I know a colleague of mine went to Korea to get that service, and Aetna is a really good insurance. When I worked in the States and I got insurance, I was also under Aetna. They transitioned to Blue Cross Blue Shield, but my dad being a retiree and going from HPMR to Aetna, that's a big difference. There's a lot of times when that insurance that we had was still Hawaii Pacific Medical Referral, and they don't even accept that. You have to pay out of pocket and get reimbursed. So let's continue to improve our outcomes and services. And again, thank you all for what you do.
Thank you, Senator Vice President.
Thank you, Chair. I'm so sorry. I know the time. Just a quick follow-up. So you stated earlier that if we are successful in increasing our Medicaid funds from 60 to 90, that perhaps maybe it could help CHCC with their their uncompensated care costs. Is that something that can be done now with the existing funds that we do receive? No. Is that something that can be covered by Medicaid in the future by modifying? Okay, so but you would have to modify the state plan in order to absorb some of those costs. Okay, thank you for the clarification. Thank you, Chair. Are you?
Thank you. Just jumping around on medical referral, I kind of saw you guys earlier. You heard the public comment by Liana, right, regarding being sent on medical referral, and then while there, they found out that there's other serious concerns, and then needing to further undergo medical referral approved services. So maybe that's something that we can talk at a later time, but those are concerns that I think if what we are hearing are justified, rather than having the person come back and then undergo through all the procedures again and then be sent off island. I think that there must be some policy that under these circumstances they can actually continue on. I just want to mention that. And the other thing, I gave the members copies of a letter I signed today. It's actually dated February 24 when I first heard about all of this, but I sent it out today. Speaking of stress, hospital, I'm concerned because there's that possibility we're hearing that Cagman Health Clinic might be preparing to close its operation because of the loss of some grant, 1.9 million grant to the members. We need to discuss this further and maybe hear them out. This is somewhat concerning because this is a service that's benefiting a lot of our people down on the other side of the island, as well as I believe Tinian and San Antonio gets covered under all this. So I send copies of the letter to the members. I think that the committee needs to meet with the Medicaid Director George, maybe in another setting. You presented us with a lot of concerns and especially on the matching concern. I think that's something that we need to address. And to Dr. Chelsea and CEO acting, CACC, thank you. And I think that with the challenges we have with medical referral, there's areas where we can help at least those that, as Senator Cruz mentioned, without that are not qualified but have some insurance coverage, maybe a little assistance with the medical facilities in these foreign countries. Because I like to say that, and I brought it up with Edna already, because with my own experience at St. Luke, it's unbelievable for our people that go there and have to face what we face there. I think that there are discussions that we need to have with Aetna to ensure that, you know, when they're there, the services and the letter of authorization, everybody knows about LOA, that you have to line up at the elevator and at the pharmacy and the office up there, and then come down and then go up there like 10 times in a day, right? And all the waiting, it's unreasonable. And I'm glad to hear from Pacifica, their representative here, that they're trying to set up a caseworker position there, and I think it will go a long way at Asia Medical, St. Luke, and maybe other facilities similarly where Aetna is being accepted. Thank you, Joe, Loke, and everyone that is here for the discussion today. I know the committee, we have the bills to discuss, but can I hear what recommendation do you want as far as the 7 bills that are here? Take a break and then come back in the afternoon? That will not conflict with the ongoing conference committee. I think the 3 of us are not members there, no, of that committee. I'm sorry? Okay. So you come back in 45 minutes to an hour? And continue 1:30. Okay? So can I get a motion to, or should we just, according to the senator, he wants to continue on the other bills, or should we? So we'll just adjourn and then go for another committee meeting. So can I get a motion?
Motion to table all of the bills that are listed on the agenda for another time. And can I do two motions one time? Motion to adjourn.
Yeah. So second.
Second.
So we adjourn in this committee meeting and take care of the bills here listed in another committee meeting. Those in favor say aye. Opposed nay. Motion carried.